Hi, I'm Kathy Lord, and today I'm going to talk about autism assessment again in this time of social distancing and try to update you about what we've learned in the last year. This work has been with the collaboration of many people, including Sophie Kim, who is at Weill Cornell Medicine, and then Allison Holbrook, Catherine Byrne, Nikki Berry, Christina Tulin, and Deanna Dow here from UCLA, and Becca Grodzinski from UNC Chapel Hill. I do need to say that I have conflicts of interest. I get royalties from WPS for diagnostic and screening instruments. At this point, not the ones I'm going to talk to you about today. And I'm on scientific advisory boards of various groups and have funding from various agencies, none of whom are responsible for this particular talk. So what's happened in the last year with autism assessment? I think that we've all dealt with social distancing and the difficulties of needing to wear masks, needing to stay at home, but we're beginning to open up and we will get to an endpoint of all of this, hopefully as soon as possible. I think another thing that's happened this year is we're much more aware of the inequities in health and many aspects of American life. And we also recognize the tremendous losses and disruption of lives that some people have experienced that we don't want to forget as we move forward, hopefully back toward normality. I think we're also aware of the importance of basic science. We wouldn't have vaccinations if we didn't have scientists who jumped right in when needed and worked and achieved something really quite miraculous with the vaccinations. But I think it also brings to mind the importance of behavior. If we didn't know about social distancing and masks and people hadn't stayed at home and really tried to avoid the spread of this virus, while we waited for science, we would have many more people very ill or dead. And that is something that we don't want to happen. But in the meantime, life goes on. And today what I'm going to do is first give you sort of a general introduction to issues I think are important in assessment and diagnosis of autism. I'm going to use autism and autism spectrum disorder, or ASD, interchangeably. I'm really going to focus on two approaches that our lab has been working on during the pandemic with the help of families and autistic children and adults, the backup from CART and colleagues there, the clinicians at CAN, and Kids Connect. So a big thank you right from the start to all the people who have contributed to this. One of the things I'm going to talk about is a temporary substitute for the ADOS, which I'll talk about in a minute, called the BOSA, that may perhaps not be so temporary, but that's a consideration. And the other is a measure of change in behavior called the BASKC. And we hope that the BASKC can tell us more about the effects of various treatments over time. They sound similar and they look similar, but they're actually two quite different things. So let's start by thinking a bit about why do we need diagnoses? I mean, particularly during a pandemic. A diagnosis should give us information available about that we've learned from other people who have the same diagnosis. Now, in some aspects of medicine, a diagnosis would give you an etiology, a cause for whatever your problem is, but not in autism. In some aspects of medicine, a diagnosis would tell you immediately what treatment you should have. In autism, we know a lot about the treatments that seem to work, but a diagnosis does not lead to a single treatment in autism. It can sometimes be a ticket for services, and that's probably the most controversial aspect of assessments in autism, is that people feel like they've got to have a diagnosis or they have to have an ADOS in order to get access to things. But really, a diagnosis should be a critical part of an adequate assessment because we want to know, we want to be able to use all that information gathered from other people who have some symptoms, at least, that are similar. But it's not in itself sufficient, and it really should be the beginning, not the end. What's very important to remember, and I've said this many times before, most of you know, but that other factors besides autism make a huge difference in the lives of children and adults with autism. And those factors include level of language, level of cognitive functioning non-verbally, adaptive skills, co-occurring problems like ADHD or depression or anxiety. And in the long run, many of these issues affect other people, not just people with autism, but people with ADHD or learning disabilities or language disorders. The things that seems specific to autism, and again, it may be specific in terms of intensity, are that people with autism generally have poorer adaptive skills than you would think, given their level of intelligence. They may be less likely, but doesn't mean never, to have friendships or close relationships. Families who have children with autism report more stress and higher levels of stress than families of kids with other kinds of developmental disabilities. But on the whole, in autism, families are more likely to be involved in treatment and often to do parent-mediated treatment as well as other kinds of things, which is a good thing. So one of the things we're looking at is this idea of a stepped care approach to assessment. And that really means that you begin by looking at everybody and seeing who might have difficulties. If you see a child or hear about a child as a pediatrician or as a family doctor or as a speech pathologist, you look at what does that child and family need. And then if you think this might be autism, then you assess for autism, but you also must get information about the other factors that I talked about, particularly language level, cognitive skills, as well as adaptive functioning and co-occurring disorders, either medical or mental health. We then want to have feedback and individual recommendations, and then we want to go back and see what's helped as a child develops or as an adult moves through the system. So we need standard diagnoses to get access to services, and that includes early intervention, although often the criteria for getting into early intervention are things like being 2 standard deviations behind in an area or 1.5 in 2 areas, which are not diagnoses. We need standard diagnoses sometimes to get access to community resource centers or like our regional centers, and insurance companies ask for standard diagnoses. So diagnostic instruments are tools that provide useful information. They are not the actual diagnosis, and they really are like getting a blood test or getting weighed or having an EKG. They shouldn't be considered a simple answer, but a piece of information. And they really do depend on what is the person who's being assessed, or who is the person being assessed, who is doing it, how much do they know? And they should be more than a stamp of approval in a neurodevelopmental disorder. Now, ideally, we would know from doing an assessment which treatments work best for whom, when. And that's something that on the whole, we don't know because we just lack the research. I also think that in this era of attention to social justice, we need to be really careful because there's a press to get kids diagnosed fast so they'll get into services. But if you remember that there is no one treatment for autism, a fast diagnosis can sometimes be nothing more than a label. And anyone who says, I could diagnose autism, I see the kid getting out of the car in the parking lot, and that's enough for me, really is being irresponsible. Because we need to know those other things about kids who have autism. We need to know about their language. We need to know about their cognitive ability. And we also want to know about their strengths. We want to spend enough time with a child to say, this child's got a great sense of humor, or this child can really focus when he's interested. I have a lot of personal concerns that what's going to happen if we have very short diagnoses is that we'll have a whole 2-tiered system where families that don't have a lot of resources will get a rapid diagnosis and a label and told to go off to their regional center here in California. And families who have more money and more time will say, I didn't like that. I'm going to find someone who really knows about autism, will at least spend a couple hours with me and get to know my child and give me a sense of what this child can do, can't do, may not do. And we really need to work together to make sure that this happens so that we don't have a system, a completely two-tiered system. It's bad enough now as it is, and it could be worse. So one alternative is to make sure that initial access to services is not dependent on a particular diagnosis or even a criteria of 2 standard deviations on a particular test. It shouldn't be dependent on a particular tool, including the ADOS. It shouldn't be dependent on a particular profession, like being seen by a psychologist or child psychiatrist or developmental behavioral pediatrician or child neurologist. On the other hand, realistically, expecting physicians and examiners to use some kind of tool is not unreasonable. There's all kinds of evidence that when people do something standardized, they follow some kind of standardized criteria, they do a better job, and we don't miss people and we don't screw things up. So we have higher accuracy. We can keep track of things if we have some kind of objective measure. When we meet a child at age 2 or 3, we can go back and see how much they've changed at 4 or 5, and we can communicate among each other, among professionals, in a much better way than if I'm just expressing my personal opinion. So somehow we need to work within systems so kids get into services and adults and aren't limited by access to things. But on the other hand, we don't allow insufficient assessment. So what we really need are all of the things here, which basically go from a discussion of the history with the family, an observation of the child in a relevant context where the child is behaving as a parent says they typically do, and then the other things which I've talked about already. So if we don't have a lot of time, if you're only allowed 15 minutes with a child, what do you sacrifice? Do you go through all of these things? And then I do think one thing that's really lost, and you'll see even in the new thing that we're suggesting, is the time to think about what are strengths, both within the child and with the family. So the ADOS, which probably most of you know, is a 45-minute series of tasks. It has different versions for children and adults of different language levels. It is given by a professional. It can be any profession, as long as someone has learned how to do this and is experienced working with this age of person and person with this kind of language. It's used by many clinics and schools because it's standardized. And that just means there is a way to do this. It's not the same all the time, but people that are learning to do it learn to do certain things so that we have a good idea of what is the range of responses that typical kids have and autistic kids have. So when the pandemic started, we experimented with the ADOS and we found that having either one person or 2 people with masks and trying to judge eye contact, facial expression, integration of gaze did not work. So our group really felt responsible, particularly me. And we realized that in the meantime, we'd been working on a 15-minute observation of social communication that I'll talk to you about later in this talk. And maybe we could use that context, those kinds of activities, to do something that could be done by parents without a mask. So we'd still have a chance to see a child interact with someone. And instead of interact with us as being clinicians, they would interact with their parents. But they could do this at home, in the clinic, and without masks. And so this is where the BOSA, which stands for Brief Observation of Symptoms of Autism, came from. And we deliberately didn't call it another diagnostic schedule because it really is intended to fill the immediate need right now. So what the BOSA is a set of materials and simple activities that a child or an adult does with another person. It takes about 12 to 14 minutes. The other person is given simple instructions about what they do, but is not supposed to be a trained clinician. In some cases, we have had kids do BOSAs with their therapists, but their therapists are generally ABA therapists. They are not diagnosticians. The person interacting is supposed to just interact and act as normal as they possibly can during this kind of weird situation. There are 3 different versions of the BOSA, and that's also true for the BASKC, which I'll talk about later. There's a version for minimally verbal children, which also can be used with adults, but with slightly different materials. There's a version for children and adults who have phrase speech, but not long sentences, and also young kids, so kids under age 8 who have fluent speech. And then there's a version which we call F1, F2, which is for fluent speakers. And there's one for kids, which could go down to 6, so overlapping with the other one, or up to about 11 or 12, and then a version for teenagers and adults. This thing can be done anywhere, which is where it's quiet and you're not distracted. So it could be done in a backyard, it could be done in a parking lot, it could be done in a clinic, it can be done with anyone. It can be done with a parent, a therapist, a researcher, and ideally, maybe a friend or a sibling. So let me show you an example of just what this looks like. So here, this mother has been sent this tablecloth that she's putting on the floor, and you'll see, and that's her son, who we think might have autism. She's sent this box of toys, and she's told where to put the toys. There's a little P for where her son is sitting, and where to put her camera on a little tiny easel. And then she's asked to play with her son for 4 minutes. Then she has 2 minutes of bubbles, and then play with him with different toys. So clean up, clean up the bubbles, come back, play with a different set of toys for 4 minutes, and then bubbles. I'm just going to show you a few seconds of this, so you'll have a sense of what we're looking at.
Can we deliver it to the? Let's deliver it. Where should we deliver it?
The mom is.
To the cake factory. Where's the cake factory? There's a cake factory. To the left or to the right? This is the cake. Okay, let's pretend this is the cake factory. Beep, beep, beep. The cakes are all delivered now.
So I would never want you to diagnose this child of just seeing this. But my point is, you can see quite a lot. So this little boy spun around. This little boy has odd intonation. This little boy is quite preoccupied with cake factories, which we wouldn't necessarily know right away. But we can actually get quite a lot of information in just a few minutes. And here we really watch this for just a few seconds.
Can we deliver it to the? Let's deliver it. Where should we deliver it? You're gonna deliver it to the cake factory. Where's the cake factory? There's a cake factory. To the left.
Okay. So this is another example, and this is a young adult with his mom who gave us permission to video him during this.
Yes. I don't tell you. Hold yours in.
So they're playing slapjack, and it's just to kind of warm them up.
Oh, you're so busy paying attention to your cards, looking at them. Want to go? Keep going. Okay. Yeah, get your pile of questions ready.
So now they're going to ask each other questions and play
All
Jenga.
right, you get a question. Right, they're right here.
What makes you happy?
Being around you.
Okay.
And sunshine and vacations and traveling. What makes you happy?
Going to the gym, going to the beach, going to the library, hanging with friends, with great friends.
Yeah.
Going on vacation.
Vacation's always
Yeah.
the happy feeling. Ready?
Yes.
No, that's not fair. Okay. All right, I'll put that right there. My turn. What makes you sad?
Man, tough one.
Yeah, you're pretty much always
the,
happy.
The rain.
The rain makes you sad?
There's nothing much to do.
Oh, so being bored makes you sad.
Yeah.
You think?
Yeah.
What else?
The
rain. You love water. I love water.
Yes, I do. I like rain, but.
So again, I would not want you to make a diagnosis from just seeing this. But the point is you can get quite a lot of information, especially if you have the full 15 minutes. And carrying these out is relatively easy to do. Each of them involves a beginning and a middle and an end, and then families can see a video beforehand of what exactly they're going to do. So the way that we score this is we first took ADOS scores and dichotomized them. So basically we looked at all of our data and we looked at where could we divide up people who were very likely to be autistic from very unlikely to be autistic. And basically then you just get a score of likely to be autistic if you have a particular item. We also got rid of things from the ADOS. So this is scored on an ADOS protocol that were highly correlated. So items that are almost always the same, or items which you couldn't score. So for example, parents didn't necessarily ask a child to report an event. So you didn't want to score that. We did factor analyses to look at how the items fell, and they fell into social communication and repetitive behaviors. And then we looked at the sensitivity, that is, could we find scores on the BOSA that identified most people with autism, and could we find scores that ruled out? And you'll see the answers. So we did this with pre-recorded videos. Coders established reliability, and we also had test retest. Now you'll see that this looks pretty miraculous to me, because over the pandemic, we were able, by mailing kits out or hand delivering kits to families who were in various projects, we were able to do this with several hundred kids. And you'll see, though, the numbers are not that big for the different modules, and they're broken up here by ADOS modules. So even though there's only 3 versions of the BOSA, minimally verbal, phrase speech, young fluent, and F's, which is F1 and F2, different materials, you actually use the 5 different modules depending on the age and language level. And you'll see this is our sample. So the first thing that Dr. Dow, who was running these analyses, did was look at factor analyses. And what we want here is we want to show that there are some items that hang together. And in fact, in this, in the BOSA, there are 2 factors. There's factors for social and factors for repetitive behavior. And these are just statistics where we would like the CFI to be 0.90. So you can see we almost pulled it off for everything. We would like the TLI to be 0.9, so we did it. And we'd like this REMC to be 0.08, and so, or under. So here we have a couple that are a little bit high, but not bad. And you can see the various items that we were able to maintain in the different modules. So the standard things like facial expression and eye contact are in all the modules, but then we have particular things, for example, frequency of vocalizations, which is non-speech vocalizations we coded in the younger kids, requesting and giving recorded in the younger kids, but we include, for example, offers information in the older kids. We have 2 factors, one that has to do with social behavior and one that has to do with repetitive behavior. And the way that this comes out is we've listed DSM-5 criteria here. And so what you can do is write your ADOS score here, look at how it's converted to BOSA, because remember, sometimes in the ADOS, the average score is not a 0, it's a 1. And so then we don't want to be counting people as if this was moving toward autism. So you indicate the BOSA, and then you can also record parent report, because basically if you see it in a BOSA, it means it exists. But if you don't see it, it doesn't mean that it doesn't exist. For example, a child might flap his hands, but he might never flap during the BOSA. The fact that you don't see it doesn't mean it never happened. So here you have a chance to go ahead and check off what parents may have told you about the same behavior in case you don't have information. And then you can make a DSM-5, or people have also used this for ICD-11. We were then able to establish cutoffs, and they're here, that were relatively sensitive. Now, again, we're talking about 12, 14, 15 minutes, depending on the version. And we were able to identify, again, about 90% of people that had clinical diagnoses of autism. This is not perfect. It's not as good as an ADOS in general, but it's also much better than, actually, as far as we can tell, clinical judgment when you aren't controlling what information people are using. Specificity, which means the ability to rule out autism, is much harder. And we actually don't have data. We were not able to see enough very young kids to know how it works here. But you can see here that in module 2 and 3 with school-age kids, you are able to rule out, this kid does very unlikely to have autism about 70% of the time. So not always. Again, so this is not as strong as an ADOS. It's not perfect, but it gives you information. And this is just an ROC curve, which just shows you, this is social communication is the blue. And we can go up here to a point where we can identify correctly about 90% of the kids with autism, and then rule out about 70% of the kids that don't have autism. This is just our agreement with each other, and over time, this is done twice in 1 week. So the good news is this really does seem fairly stable, and we were able to teach people to use the ADOS in this way with quite good reliability. So the reality is, though, this does not replace the ADOS. Certain symptoms are not as readily apparent. In the ADOS, you have 45 minutes. We have toys in there designed to try to get kids to show us if they're going to have repetitive behaviors. Certainly in highly verbal adults, many people are quite capable of having a conversation for 15 minutes and never mentioning a preoccupation. It also means that some parents are incredibly good at making their kids look good. We try to tell them, please don't do this, but it's almost automatic. And so, or kids may be different with their parents. They may be more grouchy and less cooperative. There isn't a severity rating, which I think is an important thing in the ADOS because we want to look at changes over time. And the cutoff for in highly verbal adults is quite low. So we've got to be careful. So on the whole, you need to also have a developmental history. You need to know medical background and parent reports of symptoms. You also do need to have somebody who's familiar with the ADOS to do the coding. The good news is we would never have done this if it weren't for COVID and needing to have something. And I think another good news is that, for example, the CAN Clinic jumped right in to using it and has provided us with many good examples of ways this can be done, even though we're not saying it should replace the ADOS. There certainly is the potential to use this as a level 2 screener, which means not in the regular doctor's office, but when you're concerned and trying to decide, should I do a full evaluation, you could certainly use this. And again, depending on how you're going to get other information, are you going to do something else that allows you to see the child's strengths? Are you going to work with the parent? Then it may be able to be used in place of an ADOS. And finally, we obviously don't have good data about what happens with non-autistic kids other than the small number of people we saw, and we need to replicate it with a sample. So I think for parents, I want to say, remember, you have the right to insist that somebody is doing a good job making a diagnosis, and you could have a very well-respected person telling you your child has autism, but if you don't think they have enough information about your child, you have the right to find somebody who does. You also have the right to be listened to and heard, and to know on what basis people are making decisions. If somebody says, I could diagnose your child in a parking lot, how? You need to know all kinds of things about your child besides diagnosis. You do need to know cognitive level. You need to know language level. You need to know where your child falls compared to other kids, both autistic and not, in terms of taking care of themselves. And in terms of things like, do they also have ADHD? Do they have motor problems? For clinicians and researchers using the BOSA, you do get ADOS items that are sorted according to DSM-5 criteria. You could do something else. So there are various other measures people have proposed, like the telepeds and the ASDPeds and or the ADI or SORF. This isn't an ADOS, and it really doesn't feel like an ADOS. You don't have time to enjoy being with a child. So it doesn't give nearly as much information about strengths, but it also does give us a chance to see a child or adult with the parent and sometimes at home. And so again, what we're looking for is the ability to sum this all up and to basically use it as a framework to make an initial diagnosis. So I'm going to switch gears and just talk about one more thing. And that is, once when we have a diagnosis, children and adults usually begin different services. But how do we know if those services are effective? Usually we have observations, but are there other ways we can measure these changes? Usually the therapists tell us, and they should know what is happening. But for example, we talked to a parent today who said their child is making more sounds. She's doing lots of things, but she isn't saying any new words. So how do we know whether she's learning these new words and not saying it? The BASKC, the instrument I'm talking about now, is not going to solve all of that problem. But again, it's another way of observing that is more objective than just what we think. And the trouble is that in fact, seeing subtle changes in social communication is really hard, particularly if you're a parent or even as a psychologist, if I really know the child well. On the whole, the diagnostic tools are not sensitive to subtle changes. And on the whole, if we're involved, if we're a therapist or a parent, we're going to be biased. There also are a huge number of different measurements that are used to assess different treatments, and that's fine, but it would be really nice to be able to compare, for example, all the NDBI treatments and see how they change something in similar ways or not. So we also need to remember that there are incredible placebo effects. So this is from a study where we were just having families, as a favor to us, wear wristbands for 8 weeks, and they had no intervention. And you can see they reported changes in behavior. They reported changes on the SRS. And then we saw the kids and we didn't see any change, but it was just because we were doing something. So the idea of the BOSK, which stands for Brief Observation of Social Communication Change, is to have something that's particularly sensitive to changes in social communication, minimize bias, so you can do this without a parent or a clinician even knowing about it, having it be flexible but standardized enough so we can compare across sites and treatments, and user-friendly, so you do not have to be a skilled person to do this, although you have to have more skill to code it. And what this gives you is not a number that means anything. These numbers here, this little guy is 19 months old, he got a 39. The number itself doesn't mean anything. What means something is the change. So his scores went down, which is good, down to 28. So he changed in 3 months of treatment. His score went down 11 points. And we can compare that to other kids who are with their mother in a similar room, in a similar treatment. Here's another little guy, this kid has more language. So he had the one for, stands for phrase speech, young, fluent. And his score just went down 5 points, but that doesn't mean it's worse, because again, we can only compare this to other kids in the same intervention. So again, we have these same 3 versions. And when we started working, we initially made a version for minimally verbal kids that worked incredibly well. So we were very excited. And then we tried to have a version for kids who could talk, and they just weren't talking, which was terrible because we knew they could talk. But then when we asked the parents to try to have a conversation with them, trying to have a conversation with a verbal 3-year-old is not particularly fun, off the seat of your pants. So we came up with the idea that we would have toys that really require both people to be looking at the same thing, and which elicited very common comments from kids. So we have this doorbell house and we have a mailbox. And we've added to the other toys then 2 minutes of a conversation where both the adult and the child are asked to talk about either this or this. And that has worked out very well. The BASKC is coded by watching the video in one half and then the other half. You watch the first half once, and then you have 13 to 15 codes that have decision trees, where you start with, did this child gesture at all? Yes. Did he show something? Yes. Did he actually use other gestures? No. Well, how often did he show things? And then at this point, you get a code. And you watch this twice just to check your codes. The kinds of things that are coded are here. And you'll see that we have a social communication factor. We have a restricted and repetitive behavior factor. We have play, which actually doesn't load on either of those factors. And then we just keep track of other difficulties, like a child who's very, very active, disruptive, or anxious, just to be sure we know that other things were going on. This is the factor analysis for this new level. So we've done this already with minimally verbal kids. This is the version for kids with phrase speech or young fluent kids. And you'll see the factor loadings are very high, except for mannerisms, which we just don't get that much of. We've had quite a big sample, and our statistics really look pretty good. It would be nice if this is 0.9 and this is under 0.8, but it's close enough. We also show that we can do this reliably, both if we give the child the same test twice in 2 days with no time in between it, he scores the same way. We can also do it, we can also test our reliability in scoring. Oh dear, this is, the good news here is, and this is from Kids Connect, this Cohen's D should actually be 0.63 and 0.55. But the point is, these are kids who are in our day patient program here called Kids Connect, which has been very gracious, and the families there of letting us test the kids before and after. These are the full scores. This is social communication, and you can see we have quite marked changes for the kids in this intervention. We don't see changes on repetitive behavior. This is not that the kids aren't making them, but it's just 15 minutes is just not enough. This is the minimally verbal kids. Oh, actually, that was the minimally verbal kids. And these are the kids with phrase speech. And you'll see we get an even bigger change in the 12 weeks of Kids Connect. So really nice changes. And I'm just going to show you some examples. And again, obviously we picked these, and I'm just going to show you little snips. So this is a little guy.
I found another transformer, but this one's smaller.
So they have the toys for 4 minutes.
Question. You press on this. Squeeze the sides. There you go. Those are its arms.
Where's his legs?
I think those are his legs.
I'm gonna save the day.
You're gonna save the day. Can I help? Did you want me to put sentences? Flower sentences? I'm gonna save the day.
Well, wait. Wait a minute. I need wavy. I have 2 eyeglasses.
You have 2 eyeglasses.
Yeah.
backwards, Mom.
Yeah, I see her over there. A villain.
I see Patrick.
I see a villain.
Where?
So this little guy is talking about himself with his own name. But I think you have to look closely, but there are many things this child does that are typical of children with autism. Remember, here we're not diagnosing, we're just counting. And here he is later.
Look
This
at
is
the
with the
people.
research assistant.
And what people?
We have some animals. We have some people. Do you think Peppa Pig could play basketball?
No.
Slam dunk. Shoot it. Whoa.
Now, does this open?
It lights up.
Where?
Press that button.
When this is, does this light up?
That one doesn't light up.
What does this one do?
That one's just pretend. We could pretend to wash our hands or wash the dishes.
And
See, maybe we could make a house for them.
wait, I can make a house.
You can.
Um,
Maybe we could make a house for Peppa Pig and her dad.
wait, that's how you make the house?
Yeah, you can just join them together like that. They fit in.
Wait, I'll put the pieces on the bottom.
Okay, you'll get the bottom.
Yep.
Okay, I'll do the outside and you do the bottom.
So I'm gonna go back just for a second. So here, if you see his BOSC social communication score here is 17. If we go back here, his score was 22. So he's gone down 5 points. And I hope you could see all the nice things that this little guy is doing. Somebody is doing a great job with working with him. This is another child. This is a child from Kids Connect. This is after COVID, so he's working with his therapist, but he's just met her.
Right there. Then we can build a house for them. We build a house for an animal? Knock, knock, knock. Knock, knock, knock. Doggy.
And then here he is, sorry. Here he is 3 months later, also with the same therapist.
Bus? Where are we going? Bye, Piggy. Bye, Piggy. Oh, let's go home. We're here. We're gonna put here. Where's our house? Should we make one? Yeah. Okay, let's make a house. Come on. Let's make together. Let's make our house. Okay, let's make our home. Okay. Oh, so cool. All right, we're making our home.
So again, very short clips, but you can see you can do this almost anywhere. In Kids Connect, there's not a lot of extra space, and they were able to accommodate us and make this happen. And this was all done over Zoom. So just to finish up about the BOSC, when we first tried this, we were able to get very nice changes with the original version, which was the minimally verbal version, with kids, even verbal kids up to age 7. And you can see the scores went down if they were in treatment, but kids 7 and older, it did not work. So we needed to make a different version. And one of the things we did was add the house and the mailbox. And then we also created a version for verbally able people, which is really for kids 8 years and older, with new items. So we're looking at different kinds of behavior in the older kids, because they're not just changing in terms of how they smile. It's not so easy to make a 10-year-old smile as it is a 2-year-old when you're right on top of them. And this consists of, we have 2 minutes of an active game to sort of wake people up. You saw the young man at the beginning in the BOSA playing slapjack or little mini basketball. We have 4 minutes of a turn-taking game, which is Jenga with social questions. So the same thing as the BOSA, and 2 minutes of conversation. And then you just do the turn taking and the conversation over again. We've been working to make this, put this online. So we have a video system courtesy of Open Health where you can watch it and code it through typing as you go along. And then you go back and use your notes to still fill out the decision tree. We're also able to look at changes in language features. And I'm not going to go through this in much detail, but we have been able to show that kids under 7, for example, have a total number of different nouns. They talk about more different things. And this is true for kids in treatment and not kids for control from that original sample. And for kids over 7, where they respond faster when the adult brings up a topic, and they're more able to bring up their own topics of conversation. So these are things that can actually be scored using machine learning with acoustic analysis without a person. So the benefits of this are the administration can be very flexible. It does not require training to do this. It does require training to code it. It's minimally structured and pretty fun, not completely fun. It's totally blindly coded. So the idea is that someone could do this in Oklahoma and upload it to a computer, and our group could code it, or someday somebody in New York could code it. It doesn't have to be us. It can be done almost anywhere. I mean, this year with COVID, we have seen people doing it on the floor, in the backyard, and a picnic bench. And you can use codes to score the ADAS, even though you're not going to treat it as an ADAS. So far, we do have small samples. Sorry. Whoops. We do have small samples. We need other people to do it. There are about 20 different places where people have done it, and we've been able to replicate some of the findings in 4 or 5 times. And we don't expect everybody to change. We want to know what treatments work and what treatments don't. And ideally, what we would really like is someday to automate all of this so that you could upload it, a computer could score it and say, you're using more nouns and you're responding faster. And that could be cheaper and more accessible. So I think I just want to end by saying we need to remember, why are we doing these things? Why are we doing assessments? If we're trying to establish a child's right to treatment, this shouldn't be dependent on a diagnosis, but it is reasonable, I think, to expect some kind of standard tool along with a clinical impression. Otherwise, this becomes an elite phenomenon where we have self-identified experts and who knows who they are, and that really does not work. So we want experts who can use tools. We also don't want to inflate the importance of one tool over another. They have different contributions. We also want to advocate for every family's right to an adequate assessment and a follow-up that monitors change. If you don't measure things in the first place, you can't tell that they changed. And the idea is that stepped care is that a child isn't getting an IQ test every year their entire life if they don't need it. If they've done well repeatedly, enough is enough. But if you're worried about it, then you test it. And everybody has baselines. Assessments are important, but not just to get a diagnosis, but to monitor progress. And we want families to move forward and to be safe. So thank you very much to the Simons Foundation, who supported this research, and Clinical Research Associates, to the research teams at UCLA, Weill Cornell, and UNC, and to all the families and children who participated. This is just my favorite slide about remembering that we're dealing with whole people here, and we want to give them all the things that they need. And this is our research group and the people that worked on both this talk and on these data. So thank you very much.